Internal intercostal, lateral to sternum, anterior cutaneous branch of sternum, anterior primary ramus. Intercostal arteries. The thoracic wall has rich blood supply. It is provided by the posterior and anterior intercostal arteries. Each intercostal space contains one posterior and two anterior intercostal arteries, upper and lower. Each intercostal space contains one posterior and two anterior intercostal arteries. Posterior intercostal artery. There are 11 pairs of posterior intercostal arteries, one in each space. They supply the greater part of the interstitial space. Origin. The first and second posterior intercostal arteries are the branches of the superior intercostal artery, a branch of the costocervical trunk. The first and second posterior intercostal arteries are the branches of superior intercostal artery, a branch of the costocervical trunk. The third to 11 posterior intercostal arteries arise directly from the descending thoracic aorta. First, course and relations in front of the vertebral column. The high posterior intercostal arteries are longer than the left because the descending aorta lies on the left side in front of the vertebral column. They pass behind the esophagus, thoracic duct, azygous vein, and sympathetic chain, but in front of the anterior aspect of the vertebral body. Anterior aspect of the vertebral body on the right side. Right posterior lungs are longer because the aorta lies on the left side of the vertebral column. The left posterior intercostal arteries are shorter and pass behind the hemizygous vein and sympathetic chain, and pass behind the hemizygous vein, left posterior artery, in front of the vertebral in front of the vertebral body in the intercostal space. In the intercostal space, the posterior intercostal artery lies between the intercostal vein and above intercostal nerve below. The neurovascular bundle in the intercostal space lies between the interstitial intercostal and intercostalis intimus muscle terminations. Each posterior intercostal artery ends at the level of the costochondral junction. Each posterior intercostal artery ends at the level of the costochondral junction by anastomosing with the upper anterior artery of the space. By anastomosing with the upper anterior border of the space. Branches. Dorsal branch. It supplies the spinal cord, vertebra, and muscles and skin of the back. It supplies the spinal cord, vertebra, muscles, and the skin of the back. Collateral branch. It arises near the angle of the rib and runs forward along the upper border of the rib below and ends by anastomosing with the lower anterior interstitial artery. Branches. Dorsal branch, collateral branch. It arises near the angle of the rib and runs forward along the upper border of the rib and ends by anastomosing with the lower anterior interstitial artery. Muscular branches. They supply intercostal, pectoral, and serratus anterior muscles. They supply intercostal, pectoral, and serratus anterior muscles. So dorsal branch, collateral branch, muscular branch. They supply intercostal, pectoral, and serratus anterior muscles. Lateral cutaneous branch. It closely follows the lateral cutaneous branch of the intercostal nerve. Lateral cutaneous branch is closely follow the lateral cutaneous branch of the intercostal nerve. Lateral cutaneous branch. Mammary branches. External mammary arteries. External mammary arteries. Internal mammary arteries. External mammary arteries. They arise from the posterior intercostal arteries of the second, third, and fourth intercostal spaces and supply the breast or mammary gland. Right branchial artery. It arises from the right third of the posterior intercostal artery. It arises from the right third of the posterior intercostal artery. Right third of the posterior artery. Anterior intercostal arteries. There are two intercostal arteries on each intercostal space. They present in the upper 9 intercostal space only. The first 6 spaces they arise from the internal thoracic artery. Internal thoracic artery. From the 7th to the 9th they arise from the musculophrenic artery. From the musculophrenic artery. From the 7th to they arise from the first to 7th they arise from the internal thoracic artery. From 7th to 9th they arise from the musculophrenic artery, one of the terminal branches of terminal mammillary artery. The 10 to 11 intercostal spaces do not extend forward enough to have anterior intercostal arteries. Termination. The anterior intercostal arteries are short and end at the level of the costochondral junction. Upper anterior intercostal artery anastomosis with corresponding posterior intercostal artery. The upper intercostal artery is anastomosis with the corresponding posterior intercostal artery. The lower anterior intercostal artery anastomosis with the collateral branch of the corresponding posterior intercostal artery. Collateral branch of the process with the collateral branch of the corresponding posterior intercostal artery. Intercostal veins. The number of intercostal veins corresponds to the number of the intercostal arteries. That is, each intercostal space contains 2 anterior intercostal veins and 1 posterior intercostal vein. The tributaries correspond to the branches of the arteries. They are present only in the upper 9 space. Each space contains 2 anterior intercostal veins and accompanies the anterior intercostal arteries. Anterior intercostal termination. Veins of upper 6 spaces and in the internal thoracic vein. Veins of the upper 6 intercostal artery and in the intercostal vein. Veins of the 7th, 8th and 9th space and in the musculophrenic vein. Posterior intercostal veins. They are present in all the spaces. Each space contains only 1 posterior intercostal vein. Each vein accompanies the posterior intercostal artery. Its tributes corresponds to the branches of the posterior intercostal artery. Its tributes correspond to the branches of the posterior intercostal. Its tributes correspond to the branches of posterior intercostal artery. Termination. The mode of drainage termination of posterior intercostal vein differs on the right and the left side. For detail on see table 17.2. The right subcostal vein joins with the right ascending lumbar vein to form the azygous vein, when left subcostal vein joins the right ascending lumbar vein from the hemizygous vein. The 5th to 8th left posterior intercostal vein join the form accessory hemizygous vein. Azygous, hemizygous and accessory hemizygous vein lie on either side of the thoracic vertebral column. Intercostal lymph vessels and lymph nodes. Lymph vessels for skin and anterior chest wall passes into the anterior axillary lymph nodes. Lymph vessels from the skin of the posterior chest wall pass into the posterior axillary lymph nodes. Anterior axillary lymph nodes, anterior axillary lymph nodes and posterior axillary lymph nodes. The lymph vessels from the anterior part of the space. The lymph vessels from the anterior part of the space drain into the anterior intercostal or internal mammillary lymph nodes. Anterior intercostal nodes. The afferent form of these nodes unites drain into the internal mammillary nodes. The afferent form of these nodes unite with those of tracheobronchial and brachiocephalic nodes to form the branchiomediastrial trunk. Brachiocephalic nodes to form the branchiomediastrial trunk, which drains into the right symphytic duct on the right side and thoracic duct on the left side. The lymph vessels from the posterior part of the space drains into the posterior intercostal nodes. The afferent form of these posterior intercostal nodes, lower 4 spaces, unites in the slender lymph trunk, which descends and drains into the cisterna chyli. The afferent form posterior intercostal nodes of upper. The afferent form posterior intercostal nodes of upper spaces drain into the right lymphatic trunk and right side on the right side and thoracic duct on the left side. Thoracic duct, lymph nodes, posterior intercostal nodes, and interior intercostal nodes or internal mammillary nodes. The posterior intercostal nodes are located in posterior part of the intercostal space on the neck of the ribs. The posterior intercostal nodes are located on the intercostal space on the neck of the rib. Posterior intercostal space. The anterior intercostal nodes lie along the course of internal thoracic artery. Internal thoracic artery. There are two internal thoracic artery, right and left, situated deep and to anterior chest wall, one on either side of the sternum origin. The internal thoracic artery, also called internal mammillary artery, arise from the first part of the subclavian artery, lower surface, about 3 to 5 centimeters above the medial end to the clavicle, on the medial end of the clavicle, opposite to the origin of the thyrocervical trunk. Course and termination. The internal thoracic artery descends behind the medial end of the clavicle of upper 6 costal cartilage. The internal thoracic artery descends behind the medial end of the clavicle and upper 6 costal cartilages and about 1 centimeter away from the lateral margin of the sternum. It ends in the 6th intercostal space by dividing into superior periepigastral and musculophrenic arteries. Relations: anteriorly formed above downwards. It is related to the following: medial end of the clavicle, interjugular vein, brachiocephalic vein, phrenic nerve, pectoralis major, upper 6 costal cartilages, external intercostal membrane, internal intercostal membrane, upper 6 intercostal nerves. Posteriorly above the second costal cartilage, it is related to the endothoracic fascia of the pleura. For the second intercostal cartilage, it is related to the endothoracic fascia and pleura. Below the second cartilage is related to the sternocostallis muscle and sternocostallis muscle, which innervates between the artery and the endothoracic fascia and pleura. Note well, the internal mammillary artery is accompanied by two venae communicants which unite at the level of third costal cartilage. Note well, mammillary artery, internal thoracic mammillary vein, which turns upward along the medial side of the artery to terminate into the brachiocephalic vein at the root of the trunk, which run upward vein. Note well, internal mammillary artery is accompanied by two vein communicants which unite at the level of the third costal cartilage to form the internal thoracic mammillary vein, which runs up to along the medial side of the artery to terminate as the brachiocephalic vein at the root of the neck. Branches: pericardiophrenic artery. It arises in the root of the neck above the first costal cartilage. It arises in the root of the neck above the first costal cartilage and descends along the phrenic nerve to the diaphragm It supplies pericardium and pleura. Mediastinal branches. They are small in contact twins which supply connective tissue, thymus and front of the pericardium. Anterior intercostal arteries. There are two for each of the upper six intercostal spaces. There are two for each of the upper six intercostal spaces. Anterior intercostal arteries. Perforating branches. They accompany the anterior cutaneous branch of the intercostal nerves. In females, perforating branches. They accompany an anterior cutaneous branch of the intercostal nerves. In females, the perforating branches of the second, third, and fourth intercostal spaces are quite large and supply the breasts. Perforating branches. Pericardial diaphragmatic branches, mediastinal branches, anterior intercostal arteries, perforating branches. Superior epigastric artery. It runs downward behind the seven costal cartilage. Behind the sternal and first costal, it runs down the end of the seven costal cartilage. Between the sternal and the first costal slips of diaphragm to enter the rectus sheath, where it ends by anastomosing with the inferior epigastric artery. It supplies anterior body wall from xiphoid process to the umbilicus. Musculophrenic artery. It runs downward and laterally behind the 7th, 8th, and the 9th costal cartilages and gives two anterior intercostal arteries to each of the 7th, 8th, and 9th intercostal space. Laterally, 7th, 8th, and 9th costal cartilages, 7th, 8th, and 9th runs downward and laterally. Musculophrenic spaces, 7th, 8th, and 9th. It pierces the diaphragm near the 9th costal cartilage to reach under surface. It supplies diaphragm and muscles of the anterior abdominal wall. Types of respiration. Respiration consists of two alternate phases of inspiration and expiration, which are associated with alterate increase and decrease in the volume of thoracic cavity, respectively. During inspiration, the air is taken inhaled, and during expiration, the air is taken out exhaled. Rate of respiration. The average rate of respiration is 18 per minute in normal resting stage of an adult. It is faster in children and slower in elderly. Merchant's mechanisms of respiration. Inspiration. Normally, the pressure within the thoracic cavity is less than the atmospheric pressure. During inspiration, the volume of the thoracic cavity increases, which creates further negative thoracic pressure. Volume of the cavity increases and consequently air is sucked into the lungs. An increase in the capacity of the thoracic cavity. An increase in the capacity of the thoracic cavity occur virtually. Increase in the capacity of the thoracic cavity occur vertically, anterior, posteriorly, and transversely, side to side, in different mechanisms. Anterior, posteriorly, transversely, and vertically. Vertical diameter. The increase in vertical diameter occurs due to the contraction of diaphragm. Theoretically, the vertical diameter of the diaphragm concavity can increase if the roof of the thoracic cavity is raised or the roof is lowered, or both. The roof of the thoracic cavity is formed by a tough suprapleural membrane. The thoracic cavity is raised, its floor, or lowered, both. If the roof of the thoracic cavity is raised or its floor is lowered, or both. The roof of the thoracic cavity is formed by a tough suprapleural membrane which is fixed and hence cannot be moved upwards. Tough suprapleural membrane. However, the floor of the thoracic cavity is formed by the freely movable diaphragm. Thus, when the diaphragm contracts, its central tendons descends and its domes are flattened. As a result, there is an increase in the vertical diameter of the thoracic cavity. Anterior posterior diameter. An increase in the anterior-posterior diameter of the thoracic cavity occurs when sternum moves forward and upward due to elevation of vertebrosternal ribs by contraction of the external intercostal muscle. Anterior-posterior diameter. An increase of the anterior-posterior diameter of the thoracic cavity occurs when sternum moves forward and upward. Sternum moves forward and upward due to the elevation of vertebro due to the elevation sternum moves forward and upward due to the elevation of vertebrosternal ribs by contraction of external intrinsic muscles. It is called pump handle movement. Each rib acts as a lever and fulcrum of which lies just lateral to the tubercle of the rib. Fulcrum which lies to the lateral of the tubercle of the rib. Thus, two arms of lever are greatly disproportional. For example, the posterior arm is very short and the anterior arm is very long. Thus, slight movement at these vertebral ends of the ribs is greatly magnified in the anterior end of the rib. Consequently, the anterior-posterior diameter of the thoracic cavity is increased. This movement is termed pumped handle-like movement because sternum moves up and down like a handle. Sternum moves up and down like a handle. Because the sternum moves up and down like a handle of the pump during respiration. Transverse diameter. The increase in transverse diameter of thoracic cavity occurs due to the external elevation of vertebrochondral ribs, vertebrochondral ribs by contraction of external intercostal muscle. This is caused by a bucket handle movement, pump handle movement, and a bucket handle. Therefore, during elevation of the ribs movement, the middle of the shaft of the ribs lie at a lower level than the plane, passing through it two ends, anterior and posterior. This arrangement resembles a bucket handle. Therefore, during the elevation of the ribs, the shafts of the ribs move outwards like the bucket handle movement. This causes the increase in the transverse diameter of the thoracic cavity. The axis of the movement passes from the tubercle of the rib to the middle of the sternum. The axis of movement passes through the tubercle of the rib to the middle of the sternum. The bucket handle movement is produced by vertebrochondral ribs. The main factors responsible for increase in various diameter of the thoracic cavity are summarized in table 17.6. The various factors responsible for increase in various diameters of the thoracic cavity is expiration. The expiration is the passive process brought about by elastic recoil of the alveoli of the lung. The expiration is expressed by the brought about by the elastic recoil of the alveoli of the lung, relaxation of the intercostal muscle and the diaphragm, increase in the tone of the muscle of the interior abdominal wall. Types of respiration. The respiration is classified into the following three types: quiet respiration, deep respiration, forced respiration. In the quiet respiration, the movements are normal and described above. The deep respiration movements described for quiet respiration are increased. The first rib is elevated by scalene and sternocleidoid muscles. In forced respiration, all the movements are exaggerated. The scapula is fixed and elevated. The scapula is fixed and elevated by the trapezius, levator scalpi. rhomboids major, rhomboids minor muscles. So the pectoralis muscles and the serratus muscles can raise the ribs. The scapula is fixed and elevated by the pectoral muscles, and serratus muscles can raise the ribs. The muscles acting during different types of respiration, for example, respiratory muscles, are enumerated in table 17.4. Posture of patient during asthmatic attack. During asthma attack, characterized by breathless difficulty in breathing, the patient is the most comfortable in sitting up, lying upwards, and fixing the arm on the bed the table. This is because the sitting position the diaphragm at the lowest level, allowing maximum ventilation. The fixation of the arm fixes the scapula. So the pectoralis muscles and the serratus muscles may act on the ribs, which they can elevate. Table. Factors responsible for the increase of the various diameters of the thoracic cavity during expiration. Diameter. Factors responsible for increase. Vertical. Descent of the diaphragm. Anterior posterior. Descent of the diaphragm. Vertical. Anterior posterior. Pump handle movement. The sternum brought about the increase of vertebral ribs. Bucket handle movement is the transverse. Vertical. Anterior posterior. Transverse. And the movement of the vertebrochondral ribs. Table. Muscle acting during different types of respiration. Types of respiration: inspiration, expiration. Quiet respiration, external intercostal muscle, diaphragm. Passive, no muscle expiration. Quiet respiration, deep muscle. Passive, no muscle, external intercostal muscle, scalene muscles in sternocleidomastoid, levator costarum, serratus posterior, superior, diaphragm. Forced respiration, quadratus lumborum, internal intercostal muscles, transverse thoracic and serratus posterior muscles. Inferior muscles. All these muscles in the above: deep inspiration, levator, scalpi, trapezius, rhomboideus, pectoralis major, serratus inferior. Anterior primary rami of all the thoracic spine nerves are intercostal nerves, except anterior primary rami of all the thoracic spinal nerves intercostal except anterior primary ramus of the 12th spinal nerve, which is an subcostal nerve. Main movements to increase the anterior posterior diameter of the thoracic activity: pump handle movement. The sternum brought about the elevation of the sternal ribs. 2nd to 6th rib. Main movements to increase the transverse diameter of the thoracic cavity: bucket handle movement of vertebrochondral ribs. Main factor responsible for increasing the vertical diameter of the thoracic cavity: contraction of the diaphragm, position of the body in which diaphragm lies at the highest level, supine position, position of body in which diaphragm lies in the lowest level, sitting position, supine position of the body of diaphragm lies in the highest level. Principal muscle of respiration: muscle of weightlifting, diaphragm. Clinical case study: a 55-year-old patient came to the hospital with complaints of weakness, loss of weight, and pain on the back of the chest. On examination, tenderness was noted on percussion in the region of the thoracic spine. Small bulges were also seen on the surface of the chest as 3 sites: lateral to the sternum in the mid-axillary line. Small bulges were found in lateral to the sternum, mid-axillary line, and lateral to the erector spinae muscle. The X-ray of the thoracic spine revealed collapse of vertebral bodies of T5 and T6 vertebrae in a perispinal soft tissue shadow. He was diagnosed as a case of Pott's disease. Question: what is a Pott's disease? Tuberculosis of spine. What is the cause of perispinal soft tissue shadow? Perispinal abscess. What mentioned the anatomical basis of a small bulge is noted on the surface of the chest wall. The pus from the region of the tubercular spine called abscess contract contract around the thoracic wall along the plane of neurovascular bundle at the points of the surface of the chest at the sides of the exit to cutaneous branches of the intercostal nerve. It is lateral to the erect spine muscle in the midmaxillary line and just lateral to the sternum. Pleura cavities, specific learning objectives. After studying this chapter, the student should be able to mention the extent of pleura and describe pleural recess on their applied anatomy. Mention the blood supply, lymphatic drainage, and nerve supply of pleura. Describe the boundaries and contents of the superior, anterior, middle, and posterior mediastinum. Write short notes on pleura, pleural recess, pulmonary ligament, and paracentesis thoracis. Enumerate sites where the pleura extends beyond the thoracic cage. Give the anatomical basis of pleural effusion, pneumothorax, and referred pain of the pleura. Enumerate difference between the parietal and visceral pleurae. The thoracic cavity is divided into three compartments: right lateral compartment, left lateral compartment, and middle compartment. Right lateral compartment, left compartment, and middle compartment. Each lateral compartment is occupied by a lung enclosed in the serous sac called the pleural cavity. The thoracic wall is divided into three compartments: right lateral compartment, left lateral compartment, the middle compartment. Each lateral compartment is occupied by a lung enclosed in the serous sac called pleural cavity. The middle compartment contains essentially all the thoracic structures except lungs. The middle compartment contains essentially all the thoracic structures except lungs, such as heart with its pericardium, great blood vessels that leave or enter the heart, structures that traverse the thorax to enter the abdomen in passing from the neck to the abdomen or from the abdomen to the neck, passing the neck to the abdomen or from the abdomen to the neck, such as esophagus, vagus nerve, phrenic nerve, and thoracic duct. Esophagus, vagus nerve, phrenic nerve, and thoracic duct. The mass of tissues and organs occupying the middle compartment forms a mobile spectrum, mediastinum, that completely separates the two pleural cavities. Pleural cavities. Each lung is enclosed in a serous sac that consists of two continuous serous membranes, the visceral and the parietal pleura. The visceral pleura invests all the surface of the lung from its shiny outer surface. The visceral pleura invests all the surface of the lung from its shiny outer surface during early embryonic life. Each lateral compartment of the thoracic cavity is occupied by a closed serous sac. Each lateral compartment of the thoracic cavity is occupied by a closed serous sac. Each lateral compartment of the thoracic cavity is occupied by a closed serous sac, which is invaginated from the medial side by developing the lung. As a result of this invagination, it is converted into a double-layered sac. The outer layer is called the parietal pleura, and the inner layer is called the visceral pleura. The visceral pleura is continuous with the parietal pleura at the root of the lung. The parietal and visceral layers are separated from each other by a slit like potential space called the pleural cavity. The pleural cavity is normally filled with a thin film of tissue fluid that lubricates the adjoining surface of the pleura and allows them to move on each other without friction. The two layers become continuous with each other by means of cuff of the pleura. As a result of this invagination, it is converted into a double layered sac. The outer layer is called parietal pleura. The visceral pleura is continuous with the parietal pleura. Inner layer is called the visceral pleura. The visceral pleura is continuous with the parietal pleura. Visceral pleura is continuous with the parietal pleura at the root of the lung. The parietal and the visceral layers are separated by each other by a slit-like potential space called pleural cavity. The pleural cavity is normally filled with a thin film of tissue fluid that lubricates the adjoining surface of the pleura and shows them to move on each other without friction. The two layers become continuous with each other by means of cleft of the pleura, each surrounding the root of the lung, consisting of structures entering and leaving the lung at the hilum of the lung, which surrounds the root of the lung, consisting of structures entering and leaving the lung at the hilum of the lung, such as principal bronchi and pulmonary vessels. To allow the movement of the principal bronchi and pulmonary vessels during respiration, the cleft of pleura hangs down to loose triangular fold called pulmonary ligament. The pulmonary ligament extends from the root of the lung as far down as the diaphragm between the lung and the mediastinum ligament. Pleura. The pleura, like peritoneum, is a serous membrane lined by the flattened epithelium mesothelium. The epithelium lining of this membrane, pleura, secretes a watery lubricant, the serous fluid. Layers of the pleura. The pleura consists of two layers, a visceral pleura and a parietal pleura. The moistened space between the two layers is called pleural cavity or vida supra. Visceral pleura, pulmonary pleura. The visceral pleura completely covers the surface of the lung except at the hilum and along the attachment of the pulmonary ligament. It also extends into the depth of the fissures of the lungs. It is firmly adherent to the lung surface and cannot be separated from it. The visceral pleura completely covers the surface of the lung except the hilum. It also extends into the depth of the fissures of the lungs. It is firmly adherent to the lung surface and cannot be separated from it. Visceral pleura. Parietal pleura. The parietal pleura is thicker than the visceral pleura, and it lies the wall of the pulmonary cavity. The parietal pleura is like a half cone. It lines the costae, diaphragm, lateral surface of the mediastinum and Simpson's fossa. Parietal pleura. The parietal pleura is thicker than the visceral pleura, and it lines the wall of the pulmonary cavity. The parietal pleura is thicker than the visceral pleura, and it lies the wall of the pulmonary cavity. The parietal pleura is like a half cone. It lies in the costae, thoracic wall, diaphragm, lateral surface of the mediastinum and Simpson's fascia. Cervical diaphragm. Subdivisions of parietal pleura. For the purpose of description, it is customary to divide parietal pleura according to the surface it lines cover on the region in which it lies. Thus, the parietal pleura is divided into the following four parts: costal pleura, diaphragmatic pleura, mediastinal pleura, and cervical pleura. Costal pleura. Subdivisions of the parietal pleura. For the purpose of description, it is customary to divide parietal pleura according to the surface which it lies covers on the region in which it lies. Thus, the parietal pleura is divided into the following four parts. Costal pleura. It lies the inner surface of the thoracic wall, consisting of rib, costal cartilages, and intercostal spaces, to which it is closely attached by a thin layer of loose areolar tissue called androthoracic fascia. In living beings, androthoracic fascia is easily separable from the thoracic wall. In living beings, androthoracic fascia is easily separable from the thoracic wall. Diaphragmatic pleura. It covers the superior surface of the diaphragm. In quiet respiration, the costal and diaphragmatic pleura are in opposition of each other. In quiet respiration, the costal and the diaphragmatic pleurae are in opposition to each other below the inferior border of the lung. Mediastinal pleura. It lines the corresponding surface of the mediastinum and forms its lateral boundary. It is reflected. Mediastinal pleura. It lies the corresponding surface of the mediastinum and forms its lateral boundary. It is reflected as a curve over the roof of the lung and becomes continuous with the visceral pleura. Mediastinal pleura. Cervical pleura. It is the dome of parietal pleura which covers the apex of lung. It extends into the root of the neck about 1 in and 2.5 centimeters above the mediastinal end of the clavicle and 2 inches 5 centimeters above the first costal cartilage. It is called cupola and covers the apex of the lung. Therefore, utmost caution should be taken while penetrating this area with an anesthetic needle. It is covered by the suprapleural membrane. The cupola covers the apex of the lung. Cupola. Relation of the cervical pleura. The relation of the cervical pleura are as follows. Anteriorly subclavian artery and scalenus anterior muscle. Posteriorly root of the first rib and structures passing in front of it. Laterally scalenus medius muscle. Medially great vessels of the neck. Pulmonary ligament. The pleura surrounds the root of the lung, similar to the cleft of the jacket around the sheath of the jacket around the wrists. It extends down a fold as a fold called the pulmonary ligament. The pleural ligament extends from the root of the lung as far down as the diaphragm between the lung and the mediastinum. The fold is filled with the loose areolar tissue and contains few lymphatic functions. The functions of pulmonary ligament are as follows. It provides a dead space into which the pulmonary veins can expand during increased venous return as during exercise. It allows the descent of the root of the lung as the descent of the diaphragm during respiration. As a result, the apex of the lung comes down from the suprapleural membrane, leaving an empty space below the membrane. Now the apex of the lung can expand into the empty space. Pulmonary ligament functions. It provides a dead space into which the pulmonary veins can expand during increased venous return as during exercise. It allows the descent of the root of the lung with the descent of the diaphragm during inspiration. It allows the descent of the root of the lung. As a result, it allows the descent of the root of the lung with the descent of the diaphragm during inspiration. As a result, the apex of the lung comes down from the suprapleural membrane. throat suprapleural membrane, leaving an empty space below the membrane. Now the apex of the lung can expand into the empty space. Surface markings of the parietal pleura. The surface marking of the visceral pleura corresponds with the surface marking of the lungs and is closely applied on their surfaces. Hence, it is described with that of the lung on page 245. The following text deals with the surface marking of the parietal pleura. The knowledge of reflection of the parietal pleura on the surface of the chest wall is of great importance while carrying out various medical and surgical procedures. Parts of the parietal pleura. The parietal pleura is divided into four parts: cervical pleura, mediastinal pleura, diaphragmatic pleura, and costal pleura. The reflection of the parietal pleura can be marked on the surface by following lines. Cervical pleura, it is marked by a curved line with convexity directed upward down from the sternoclavicular joint to the junction of the medial third and the middle third of the clavicle. To the junction of the medial third and middle third of the clavicle. The summit of the dome of the pleura lies 1 inches or 2.5 centimeters above the medial one-third of the clavicle. It covers the apex of the lung. The sternoclavicular joint to the junction of the medial third and the middle third of the clavicle. The summit of the dome of the pleura lies 1 inch 2.5 centimeters above the medial one-third of the clavicle. It covers the apex of the lung. Mediastinal pleura. It is marked by anterior costo-mediastinal line of pleural reflection. It differs on the two sides. On the right side, it extends downward and medially from the right sternoclavicular joint to the midpoint of the sternal angle, and then descends vertically up to the midpoint of the sternal joint. On the left side, it extends downward and medially from the left sternoclavicular joint to the midpoint of the sternal angle, then descends vertically only up to the level of the fourth costal cartilage. It then arches outward to reach the lateral margin of the sternum and runs downward a short distance lateral to this margin to reach the sixth costal cartilage, about 3 centimeters from the midline, leaving a part of the pericardium directly in contact with the anterior chest wall, bare area of the heart. Diaphragmatic pleura. It is marked by inferior postdiaphragmatic line of the pleural reflection. It passes laterally around the chest wall from the lower limit of the anterior line of pleural reflection. It differs slightly on two sides. On the right side, the line of reflection starts from the G5 junction process joint, external joint, or behind the G5 process and cross the 8th rib in the midclavicular line, 10th rib of the midaxillary line, and 12th rib of the lateral border of the erector spine. 2 centimeters lateral to the spine of the thoracic 12 vertebra. On the left side, the line of reflection starts at the level of the 6th costal cartilage, about 2 centimeters lateral to the midline. Therefore, it follows the same course as the right side, posterior line of the pleural reflection. It ascends from the end of the inferior line, 2 centimeters lateral to the thoracic 12 spine, along the vertebral column to the point, 2 centimeters lateral to the spine of the cervical 7 vertebra. The costal pleura becomes the mediastinal pleura along the line. Costal pleura. It lies the thoracic wall, from which it is separated by endothoracic fascia, a layer of loose areolar tissue. Note well, the inferior margin of the lung passes more horizontally than the Inferior margin. The inferior margin of the lung passes more horizontally than the inferior margin of the pleura. Consequently, it crosses the sixth rib in the midclavicular line, eighth rib in the mid-axillary line, and 10th rib in the lateral border of the erector spinae. 10th rib at the lateral border of the erector spinae. The ribs crossed by the inferior margin of the lung and pleura in the midclavicular line, mid-axillary line, and lateral to the erector spinae are compared below. Inferior margin of the lung, 6th rib, 8th rib, and 10th rib. Inferior margin of the pleura, 8th rib, 10th rib, and 12th rib. Recess of the pleura. Normally, the space between the parietal pleura and visceral pleura is only a potential space, and it is filled with the film of the serous fluid. However, in arcus of the pleural reflection on the diaphragm and mediastinum, the space between the parietal and the visceral pleura is greatly expanded. These expanded regions of the pleural cavity are called pleural recess. They are essential for the lung expansion during deep inspiration. Thus, pleural recess serves as reserve space for the pleural cavity for the lungs to expand during deep inspiration. The recesses of the pleura are follows: costodiaphragmatic recess, right to left; costomediastinal recess, right to left. Note 1. In addition to above recess of the pleura, there are three more small recesses, namely right and left retroesophageal recess. These are formed by the reflection of the mediastinal pleura. Diaphragmatic pleuritis is marked by costodiaphragmatic recess and costomediastinal recess. In addition to above recess of the pleura, there are three or more small recesses, namely right and left retroesophageal recess. These are formed by the reflection of the mediastinal pleura behind the esophagus. Each recess is thought to be occupied by a part of the lung and contributes to the retrocardiac space in the radiographic of the chest. Infracardiac recess. It is a small recess of the right pleural sac that sometimes extends beneath the inferior vena cava. Costodiaphragmatic recess is located inferiorly between the costal and the diaphragmatic pleura. Vertically, it measures about 5 cm, lies opposite to the 8th and the 10th rib along the mid-axillary line. The costodiaphragmatic recesses are the most dependent parts of the pleural cavity. Hence, the fluid of the pleural effusion is first collected in these sites. Costomediastinal recess. It is located anteriorly between the costal and mediastinal pleurae. The right costomediastinal recess is possibly occupied by the anterior margin of the right lung, even during quiet breathing. The left costomediastinal recess is quite large due to the presence of the cardiac notch in the left lung. Its location can be confirmed clinically by percussion of the chest wall as one moves during tapping from the area of the underlying lung tissue to the area of the left costomediastinal recess occupying by the lung tissue. A change in tone from resonant to dull is noticed. Thus, this is called the area of superficial cardiac dullness. Costomediastinal recess. It is located anteriorly between the costal and mediastinal pleura and lies between the sternum and costal cartilage. The right costomediastinal recess is possibly occupied by the anterior margin of the right lung. The left costomediastinal recess is large due to the presence of the cardiac notch of the left lung. This location can be confirmed clinically by percussion of the chest wall. Percussion. as one moves during tapping from the area of the underlying lung tissue to the area of the left costomediastal recess occupying by the lung tissue. A change in tone from resonant is to dull is noticed. This is called the area of superficial cardiac dullness. Radiological appearance of the pleural effusion. When a small quantity of fluid is accumulated in the costodial phragmatic recess, pleural effusion, the costodiaphragmatic angle is obtained. Weighting of the angle, figure 18.6. It is seen as a radiopexo with a fluid line in the chest X-ray. This may be the first indication of the pleural effusion. Therefore, recesses of pleura are examined routinely in the chest radiographs. The costodiaphragmatic recess lies opposite to the 8th and the 10th rib in mid-axillary line. Nerve supply of the pleura. The parietal pleura develops from the somatopleuric layer of the lateral plate of the mediastinum. Hence, it is supplied by the somatic nerves and is sensitive to pain. Costal and peripheral parts of the diaphragmatic pleura are supplied by the intercostal nerves. Mediastinum and central parts of the diaphragmatic pleura is supplied by the phrenic nerves. Intercostal nerves and phrenic mediastinal. The visceral pleura develops from the splanchnoplanic layer of the lateral plate in the mesoderm. Hence, it is supplied by the autonomic nerves T2 to T5 and is insensitive to pain. Referred pain of the pleura. The pain from the central diaphragmatic pleura and the mediastinal pleura is referred to the neck or the shoulder through phrenic nerves C3 to C5 because the skin at these sites has the same segmental supply through the supraclavicular nerves. Blood supply and lymphatic drainage of the pleura. Blood supply of the parietal pleura is the same as the thoracic wall, and blood supply of the visceral pulmonary pleura is the same as that of the lung. Table 18.1 enumerates the difference between the parietal and visceral pleurae. Clinical correlation. Pleurisy or pleuresis. It is the inflammation of the parietal pleura. Clinically, it presents as pain, which is aggravated by respiratory movements of the radiates in the thoracic and abdominal walls. It is commonly caused by pulmonary tuberculosis. The parietal surface becomes rough due to the accumulation of inflammatory residue. Due to the roughening of the pleural surface, frictions occur between the two layers of the pleura during respiration movements. Thus, pleural rub can be heard with a stethoscope on the surface of the chest wall. During inspiration and expiration, the collection of the serous fluid or blood and pus in the parietal cavity is termed hydrothorax, pleural effusion, pneumothorax, hematothorax, and pyrothorax, respectively. Pleural effusion. Normally, the pleural cavity contains only 5 to 10 milliliters of clear fluid that lubricates the pleural surface to allow the smooth movements without friction. The excessive accumulation of fluid in the pleural cavity is called pleural effusion. It usually occurs due to the inflammation of the pleura. The pleural effusion leads to the decreased expansion of the lung and site of effusion. Clinically, it can be detected with the decreased breath sounds and dullness of percussion on the site of the effusion. Thoracocentris pleura tap. It is procedure by which an excess fluid is aspirated from the pleural cavity. It is performed with the patient in sitting position. Usually, the needle is inserted in the 6th intercostal space in the mid-axillary line. The needle is inserted into the lower part of the intercostal space along the upper border of the rib to avoid injury to the sternocostal nerves and vessels. The pleural fluid is located by percussion of real-time ultrasound. The needle passes in succession through skin, superficial fascia, serratus, anterior costal muscles, androthoracic fascia, and parietal pleura to reach the pleural cavity. Accumulation of air in the pleural cavity is called pneumothorax. Spontaneous pneumothorax, as the name suggests, under this condition air enters the pleural cavity suddenly due to the rupture of the emphysematous valley of the lung. Open pneumothorax. This condition occurs due to the stab wounds on the thoracic wall, piercing the pleura, leading to the communications of the air of the pleural cavity with the outside atmospheric air. Consequently, each time when the patient inspires, the air is sucked into the pleural cavity. Sometimes the clotting and the layers of the thoracic wall combine to form a valve so that air enters through the wound during inspiration but cannot exit through it. In this circumstance, air pursues pumps up continuously in the parietal cavity on the wounded side, which pushes the mediastinum to the opposite healthy side. This is called tension pneumothorax. The tension pneumothorax is characterized by the collapse of the lung on the affected side and the compression of the lung on the healthy side. Referred pain of the pleura. The central part of the diaphragmatic pleura and mediastinal pleura are innervated by the phrenic nerves. Hence, irritation of the central pleura causes referred pain to the tip of the shoulders, with the left shoulder due to the splenic rupture, Grant's sign, and pain on the right shoulder due to the cholecystitis. The peripheral part of the diaphragmatic pleura and the costal pleura are innervated by intercostal nerves. Hence, irritation of these regions cause referred pain to those thoracic and abdominal walls. Most dependent part of the pleural cavity, costodiaphragmatic recess. A 30-year-old female visited the hospital and most dependent part of the pleural cavity, costodiaphragmatic recess. The most preferred site for the pleural aspiration, mid-axillary line in the sixth intercostal space. Nerve providing sensory innervation to the parietal pleura, overlying the right dome of the diaphragm, right phrenic nerve. Area for superficial cardiac dullness, area of the front of the chest, left to the sternum between the fourth and sixth cartilages. Key structure present in the mediastinum, heart and structures transporting air, blood and food. A 30-year-old female visited the hospital and complained that she had been feeling severe pain on the right side of the chest for the past 2 weeks and has little difficulty in breathing. She also told that pain often radiated in the anterior abdominal wall. In auscultation, the doctor noticed the absence of breath sounds over the inferior lobe on her right lung. The X-ray of the chest view revealed blurting on the right costodiaphragmatic angle and the line on the fluid level. She was diagnosed as case of pleural effusion. What is pleural cavity and pleural effusion? Potential space between the parietal and visceral layers of the pleura. Potential space between parietal and visceral layer of the pleura. Accumulation of serous fluid in the pleural cavity. Enumerate the recess of the pleura, right and left costomediastinal recess and the right and the left costodiaphragmatic recess. Costomediastinal recess and right and left costodiaphragmatic recess. What is the anatomical basis of radiation of pain of the anterior abdominal wall? The peripheral part of the diaphragmatic pleura and costal pleura are supplied by intercostal nerves. The lower 5 Intercostal nerves also supply the skin of the muscles and the abdominal wall. Hence, the pain is often referred to the inferior abdominal wall. Mention the cause of the pleural effusion and site where pleural fluid accumulates first. Inflammation of the pleura. Costal pharmatic recess being most dependent. Note 12. Key points to remember during the osculation of the lung. The superior lobe of the right lung is audible above the fourth rib. The superior lobe of the right lung is audible above the fourth rib. The middle lobe of the right lung is audible between the fourth rib and the sixth rib anteriorly. The lower lobes of both lungs are audible between sixth rib and in front, below sixth rib and on the front. The inferior lobes of the right and the left lungs are best examined on the back. The inferior lobes of the right and the left lung are best examined on the back, especially in the region of the triangle of osculation. The right lobes of the both lungs are audible between the sixth rib on the front. The inferior lobes of the right and the left lung are best examined on the back, especially on the region of the triangle of auscultation. Internal structure of the lung. The lung is mainly made out of intrapulmonary bronchial tree, which is concerned with the condition of air to flow from the lung, and pulmonary units, which are concerned with the gaseous exchange within the lung. For the delegated structure, see textbook on histology. Bronchial tree. The bronchial tree, also called the respiratory tree, consists of the bronchi, pulmonary, secondary, and tertiary, and the bronchioles, terminal and respiratory. The primary, secondary, and tertiary bronchi are also called the principal, lobal, and segmental bronchi, respectively. Functions of the bronchial tree: to provide a gateway for the air to move into the out of each lung, to trap debris and pathogens by the mucous lining, to send atmospheric air into pulmonary units for exchange of gas to take place. The respiratory bronchioles aerolate pulmonary units. The various components of bronchial and pulmonary units are described in the following text. Principal bronchi. The trachea divides outside the lung at the level of the lower border of the thoracic four vertebra into the two pulmonary principal bronchi right and left, for the right lung and the left lung respectively. As seen in bronchoscopy, lower end of the trachea divides into carina, a hair-like ridge, into the right and the left principal bronchi. Right principal bronchi is shorter, wider, and more vertical, and is about 1 inch (2.5 cm) long, and lies more or less on the line of the trachea. Left principal bronchi. It is narrower, longer, and more horizontal than the right. It is about 2 inches long and does not lie in line with the trachea. The long axis of the right bronchial bronchus deviates about 25 degrees from the long axis to trachea, where the long axis of the left principal deviates about 45 degrees from the long axis of the trachea. The left principal bronchus passes to the left below the arch of the aorta and in front of the esophagus. The difference between the right and the left principal bronchi are summarized in table 16.3. Lower end of the trachea and its main branches, as seen in bronchoscopy. Source Gray's Anatomy for Students. Table: difference between right and left principal bronchi. Right principal bronchi. Right principal bronchi shorter and wider, more vertical, lies more or less in the line with tracheal lumen, forms an angle 25 degrees in the middle of the trachea. Long and narrow left principal bronchi, 5 cm long, more horizontal, does not line with the line of the tracheal lumen, forms an angle of 45 degrees with the middle of the trachea. Clinical correlation. Aspiration of the foreign bodies into the right principal bronchi. The inhaled foreign bodies usually enter the right principal bronchi because it is shorter, wider, and in line with the trachea. Right principal bronchi. Since the inhaled foreign particles tend to enter in the right principal bronchus, hence in the right lung. As a result, lung abscess occurs more commonly in the right lung. Bronchoscopy. It is a procedure in which a flexible fiber optic bronchoscope is introduced in the trachea to visualize the interior of the trachea and bronchi. The carina and a hill-like median ridge at the bifurcation of the trachea into two principal bronchi is an important landmark visible through the bronchoscope. The widening and distortion of the angle between the principal bronchi, shortening the position of the trachea seen in bronchoscopy is a serious prognostic sign seen in usually indicates the carcinomatous involvement of trachea bronchial lymph nodes. The carina of the trachea is also a very sensitive area for cough reflex. Bronchogenic carcinoma. It is the commonest cancer in the males, especially in chronic cigarette smokers. It usually arises from the epithelial lining of the bronchi and forms well circumcised gray-white mass on the lung. The presence of circular shadow, popular called coin shadow, is a plate X-ray chest PA view, may be the only finding in the otherwise asymptomatic patient. Metastasis. The bronchogenic carcinoma may spread metastasis to brain by both aerial and venous routes as follows. Terrestrial route. Long capillaries, pulmonary vein, left atrium, left ventricle, aorta, internal carotid and ventral arteries, brain. Venous route. Bronchial veins, vagal vein, external vertebral venous plexus, intervertebral venous plexus, and cranial dual venous sinus, brain. Lobar bronchi. The right principal bronchi gives rise to the first bronchial branch. Superior lobar branches before it enters the lung. The enters the right lung through its ileum and divides into right and left lobar bronchi, one on each middle and inferior lobes of the right lung. The left principal bronchus, on entering the lung, divides into two lobar bronchi, superior and inferior, one for each lobe of the left lung. Tertiary segmented bronchi. Each lobar bronchus divides into segmental bronchi, one for each bronchio-pulmonary segment. On the right side, there are superior lobar bronchus gives rise to the three bronchio-pulmonary segments: apical, posterior, and interior. Mnemonic: a public pathy. Middle lobar branches gives rise to medial and lateral bronchio-pulmonary segments. Easy to remember: middle and lateral. Inferior lobar bronchus gives to superior medial basal, interior basal and lateral basal, and posterior basal. Mnemonic: seed makes another little plant. On the left side, these are superior lobar bronchus gives rise to 5 bronchio-pulmonary segments: apical, posterior, and interior, superior lingular and inferior lingular. Mnemonic: a public pathy seen in the political leaders after election. Inferior lobar bronchus gives rise to the first bronchio-pulmonary segments. For example, superior, medial, basal, anterior basal, lateral basal, and posterior basal. This can be remembered in a way similar to right lobe. This segmental bronchi divides repeatedly to form very small bronchi called terminal bronchioles, about 1 mm in diameter. The terminal bronchioles give the respiratory bronchioles less than 1 mm in diameter, which lack cartilages in their walls, hence mainly made out of stomach muscles. Each respiratory bronchiole aerates a small portion of the lung called pulmonary units, which is concerned with gaseous exchange with the lung. Pulmonary units. Each pulmonary unit consists of alveolar ducts, atria, air circulates, and alveoli. Note well. The respiratory bronchiole represents the transitional zone part between the conducting and respiratory portions of the respiratory system. The alveoli are specialized sac-like structures that form greater part of the lung. They are the main sites for the gaseous exchange of oxygen and carbon dioxide between the inspired air and blood. Clinical correlation. Emphysema. Under the condition alveoli of lungs are damaged by chemical released by pollutants, clinically it presents as the shortness of breath and chest appears barrel-shaped in chest cardiograph. Arterial circulation of the lung. The lungs have dual blood supply. That is, they are supplied by two sets of arteries, namely bronchial arteries and pulmonary arteries. The dual blood supply to lung is functionally different. Bronchial arteries. The bronchial arteries supply oxygenated blood and nutrients to the bronchial tree associated pulmonary tissue and visceral pleura. The right lung is supplied by one bronchial artery which arises from the right third posterior intercostal artery or from the upper left bronchial artery. The left lung is supplied by two bronchial arteries which arise from the descending thoracic aorta. Pulmonary arteries. The pulmonary arteries supply deoxygenated blood to the lungs for oxygenation. Once the blood is oxygenated, it brought back to heart by four pulmonary veins. There is one pulmonary artery on each lung. They are the branches of the pulmonary trunk. The right and left pulmonary arteries lie anterior to the principal primary bronchi as they enter the ileum of the respective lungs. The right pulmonary artery is crossed superiorly by the arch of the azygous vein, whereas the left pulmonary artery lies inferior to the arch of the aorta at the level of the thoracic 5 vertebra. The pulmonary arteries divide into lobar branches in the hilum and the subsequent divides into the terminal and segmental branches. The segmental branches branch successively corresponding with the segmental branches of the bronchial tree. Venous drainage of the lung. Venous blood from the lung is also drained by two sets of veins, namely bronchial vein and pulmonary vein. Bronchial veins. The bronchial vein drain the deoxygenated blood from the bronchial tree and pulmonary tissue. There are two bronchial veins on each side. The right bronchial vein drains into the azygous vein. The left bronchial vein drains to the hemizygous vein and the left superior intercostal vein. Pulmonary veins. The pulmonary vein drains the oxygenated blood from the lungs. There are four pulmonary veins, two on each side. The pulmonary veins do not accompany the pulmonary arteries. The tributaries of the pulmonary veins are intersegmental, while branches of the pulmonary arteries are segmental in distribution. Clinical correlation. The pulmonary veins are obstructed. The oxygenated blood from the lungs is drained by bronchial veins. Pulmonary veins are obstructed. If pulmonary veins are obstructed, the oxygenated blood at lung are drained by bronchial veins. Note well, all the veins in the body drain deoxygenated blood except pulmonary veins, which drain oxygenated blood from the lungs. All the arteries from the body supply oxygenated except pulmonary arteries, which supply oxygenated blood to the lungs. The bronchial arteries provide nutrition to the bronchial tree as far as the respiratory bronchioles, that is that is non-respiratory respiratory portion of the lungs. The respiratory portion of the lungs are nourished by the pulmonary arteries, beds, and atmospheric air in the alveoli. Lymphatic drainage. The lymphatic drainage of the lung is critically important because lung cancer spreads by lymphatic path. The lymph is drained by two sets of lymphatic vessels, superficial vessel and deep vessel. Superficial lymph vessel. These vessels drain the peripheral lung tissue lying beneath the visceral pleura and from the superficial plexus beneath the visceral pleura. The vessels from the plexus pass around the border and margin of the fissures of the lung to reach the hilum, where they drain into bronchopulmonary higher lymph nodes, deep lymph vessels. These vessels drain the bronchial tree, pulmonary vessel, and connective tissue, septa, and from the deep plexus. These vessels from the deep plexus run along the bronchi and pulmonary vessels towards the hilum of the lung, passing through pulmonary lymph nodes located within the lung substrate, and finally drain into bronchopulmonary hilar lymph nodes. Thus, both superficial and deep lymphatic plexus drain into bronchopulmonary hilar lymph nodes. From higher lymph nodes, the lymph is drained into the superior and inferior bronchial lymph nodes, located superior and inferior to the bifurcation of the trachea. Bifurcation of the trachea, respectively. The nodes in turn drain into pre and paratracheal lymph nodes and right and left bronchiodistal lymph trunk, which finally drain into the right lymphatic duct and the thoracic duct on the right and the left side, respectively. Note well, all the lymphs from the lung is drained into tracheobronchial lymph nodes located at the tracheal bifurcation, which in turn drain into brachiomediastinal lymph nodes. Nerve supply. The lung is supplied by both parasympathetic and sympathetic nerve fibers. The parasympathetic fibers are divided from the vagus nerve. The parasympathetic nerves are derived from the vagus nerve, and sympathetic nerves are derived from the T2 and T5 spinal segments. Both provide major supply to the bronchial muscles and secretomotor supply and secretomotor supply to the mucous glands of the bronchial tree. Both provide motor supply to the bronchial muscles and secrete supply to the mucous glands of the bronchial tree. The parasympathetic muscles cause bronchostriction or bronchospasm. The parasympathetic cause bronchostriction or bronchospasm, vasodilation, and increased mucus secretion. The sympathetic ducts causes bronchodilation, vasoconstriction, bronchoconstriction or vasodilation, and sympathetic causes bronchodilation and vasoconstriction and decrease the mucus secretion. After efferent impulse arising from the bronchial walls to pass to the central nervous system through both sympathetic and parasympathetic fibers. Bronchial asthma. It is common disease of the respiratory system. It occurs due to bronchospasm, a spasm of the smooth muscle of the wall of bronchioles that reduces the diameter of the bronchioles. As a result, the patient has great difficulty during expiration. Through inspiration, it is accomplished normally. The airflow is further impeded due to the presence of successive mucus, which then is unable to clear because an effective cough cannot be produced. Clinically, the asthma is characterized by difficulty in breathing and wheezing. The sympathomimetic drug such as epinephrine causes bronchodilation and relieves from the bronchial asthma difficulty in breathing. The distal portion of the bronchial tree has no cartilage in its wall. Its wall is made out of only smooth muscles, hence the lumen gets blocked by bronchospasm. Bronchiectasis, bronchiectasis. It is a clinical condition in which bronchi and bronchioles are dilated permanently as a result of chronic necrotizing infection. They become filled with pus, leading to airway obstruction. The basal segment and the lower lobe are prone to this condition. Aspiration pneumonia. In supine position, aspirated material usually enters the superior apical segment of the lower lobe, especially on the right side, for it is the most dependent segment in the position. It leads to the collection of secretions that may obstruct the bronchus, leading to the collapse of the superior segment of the lower lobe. Atelectasis and pneumonia. Pulmonary embolism. It is blockage of pulmonary arteries by the thrombus fat and air. Thrombus usually arises from the distal veins. For example, blood clots travel to the lung from the deep veins of leg. Fat following a bone fracture, when fat surrounding the bone enters the broken vessel. Air. Trapped air bubbles in vessel form following a cannulation in the neck region. Effect. Reduced lung perforation leading to decreased blood oxygenation. Clinical features: dyspnea, chest pain, tracheopnea, cough, and homeoptosis and hemoptysis. Cyanosis. Bronchopulmonary segments. The bronchopulmonary segments are well defined, wedge shaped sectors of the lung, which are aerated by tertiary segmental bronchi. Segmental. Characteristic features: it is a subdivision of the lobe of the lung. Characteristic features: bronchopulmonary segments. It is a subdivision of the lobe of the lung. It is pyramidal in shape with the apex directed towards the hilum and the base directed towards the surface of the lung. It is pyramidal in shape with the apex directed up towards the hilum and the base directed towards the surface of the lung. It is surrounded by connective tissue. It is aerated by the segmental tertiary bronchus. Each segment has its own artery, a segmental bronchi of pulmonary artery. Each segment has its own lymphatic drainage and autonomic nerve supply, drained by intersegmental veins, tributary of pulmonary veins. Surgically resectable. Thus, bronchopulmonary segments are the smallest well-defined, independent anatomic, functional, and structural units of lungs. Independent anatomical functional segments of the lungs. Therefore, they can be isolated and removed without affecting adjacent regions. Note well the segmental veins. The tributary of pulmonary veins runs segmental veins. The tributary of pulmonary veins run in the intersegmental plates of the connective tissue. Tributaries of pulmonary veins. Number of nomenclature of bronchopulmonary segments. The number of bronchopulmonary segments vary among different books, the different authors. It may vary from 8 to 10 in each lung, but in this book, the number is given according to one accepted by the International Congress of Anatomoscists. According to each lung contains 10 bronchopulmonary segments. The segmental bronchi are given in their numbers as listed in table 19.4. The lobular bronchi are also shown on figure 19.9 and 19.21. Segmental bronchi of the lungs. Main, lower and the segmental bronchi are also shown on C. Common stem of 7 and 8 segmental bronchi. There are 10 segments in each lung. They are named the numbers of tables 19.4. The bronchopulmonary segments of the right and the left lung are shown on figure 19.2 and 19.21 respectively. Right lung, superior, apical, posterior, anterior, middle, lateral, medial, inferior, superior apical, medial basal, anterior basal, lateral basal, posterior basal, superior apical, posterior, anterior, superior lingual, lingular, and inferior lingular, posterior medial basal, lateral anterior basal, lateral basal, posterior basal. In the left lung, the apical and the posterior segment is upper lobe fused to form the. In the left lung, apical and posterior segments. Fused to form the apicoposterior segment. Similarly, the inferior lobe of the right lung, anterior basal and the medial basal segments often fuse to form the anterior medial basal segment. Aspiration of material in supine position. In the left lung, the apical and the posterior segments in the upper lobe fuse to form the anterior posterior segment. Clinical correlation. Aspiration of material in supine position. In both lungs, the apical segment of the lower lobe is supplied by the segmental bronchus, lung 6. Both lungs, apical segment of the lower lobe. Apical segment of the lower lobe is supplied by the segmental bronchi of lung 6, which is the highest bronchus to arise from the posterior aspect of the bronchial tree, which is arise from the posterior aspect of the bronchial tree. Hence, material aspirated in supine position from the comatose patient tend to gravitate to the superior segment of the lower lobe, usually of the right lung. Segmental resection of the lung. The knowledge of the bronchopulmonary segments has led us to advancement in conservating lung surgery, since each segment is an independent functional unit having its own bronchiovascular supply and potential planes of separation exist between the segments. Localized chronic disease, each as tuberculosis, bronchiectasis, or benign neoplasm, is restricted to one segment. It is therefore possible to dissect out and remove the diseased segment and leave the surrounding tissue intact. This procedure is called the segmental resection. During segmental resection, it is important not to ligate intersegmental veins, as they will interfere with the venous drainage of the surrounding highly healthy segments. Segmental resection is often carried out in bronchiectasis. Compare components of tracheobronchial tree. Trachea, bronchi, and bronchioles. Components. Commonest cancer of the lungs, bronchiogenic carcinoma. Commonest type of bronchiogenic carcinoma, adenocarcinoma. Lung, most commonly affected by bronchogenic carcinoma, right lung. Commonest site of pulmonary tubules, apical regions of the lung. Most common site of lung disease, right low lobe. Bronchopulmonary segment, most commonly involved in aspiration pneumonia. Superior segment of the lower lobe of the right lung. Inhaled particles mostly enters into right principal bronchus. Commonest site where the aspirated material enters, where the person is sitting. Right inferior lobe. Number of alveoli in both lungs, about 300 million. A smallest resectable unit of bronchopulmonary segment of the lung. Principal bronchi of the lung. Exchange of O2 and CO2 between the inspired air and the lung in capillaries. A heavy smoker 16-year-old male visited the hospital and complained that he lost 10 kgs of his weight in the past 3 months and has persistent cough through the blood-stained sputum. It also through the blood-stained sputum. He also noticed the loss of sweating on the right side of his face. On physical examination, the doctors found partial ptosis and constriction of the pupil on his right eye. X-ray PAV revealed a radiopac shown in the apical region of the right lung. Biopsy revealed malignancy. A diagnosis of malignancy of the apex of the right lung was made. Questions. Enumerates the posterior relation of the apex of the lung. Enumerate the posterior relation of the apex of the lung. Mention the anatomical basis of loss of sweating in the right lung of the face and partial ptosis and constriction meiosis of the right lung and constriction meiosis of the right lung. What is the bronchopulmonary segment? What is the most dependent bronchopulmonary segment in supine position? Answers. For medial to lateral, there are sympathetic chain, highest intercostal vein, superior intercostal vein, and ventral ramus of the right thoracic spinal nerve. Involvement of the right sympathetic chain causing Horner's syndrome. Involvement of the right sympathetic chain, Horner's syndrome. Pyramid-shaped segment of the lung lobe arose by the traratory bronchus. It is the smallest resectable unit of the lung. Apex superior segment of the lower lip. Curvatures. The cervical portion of the esophagus commences in the midline, then inclines slightly to the left of the middle at the root of the neck, slightly to the left of the root of the neck, enters the thoracic inlet, passes through the superior mediastinum at the level of the thoracic 5 vertebra. It returns to the midline at the level of the thoracic 5 in the left, and then returns to the midline of the thoracic 5. Returns to the midline at thoracic 5. At thoracic 7 again derivates to the left and inclines forward to pass in front of the descending thoracic aorta. And inclines forward to pass in front of the thoracic aorta and pierces the diaphragm. Pass in front of the descending thoracic aorta. In front of the descending thoracic aorta. And pierces the diaphragm 2.5 centimeters to the left of the middle. Pierces the diaphragm 2.5 centimeters left to the middle. It returns to the middle and thoracic 5 at midline. Thoracic 5 at midline. Thus, esophagus presents the following curvatures. 2 side-to-side curvatures both toward the left. 2 side-to-side curvatures both toward the left. First, at the root of the neck, before entering the thoracic inlet. Second, in the thoracic 7 vertebra before passing into the descending thoracic aorta. two anterior posterior curvatures. First, corresponding to the curvature of the cervical spine, corresponding to the curvature of the cervical spine. Second, corresponding to the curvature of the thoracic spine. Cervical spine and thoracic spine. Contractions. Normally, there are four sides of anatomical contractions. Narrowing of esophagus. The distance of each contraction is measured. Each contraction is measured from the upper inferior teeth. The first contraction are as follows. The first contraction at the pharyngo-esophageal junction, about 15 centimeters 6 inches from the incisor teeth. The first contraction is about 6 inches from the pharyngeal the first contraction, the pharyngeal esophageal junction, pharyngo-esophageal contraction. Pharyngo-esophageal contraction is about 6 centimeters incisor to teeth. 6 inches. Second contraction is crossed by the arch of the aorta. Is crossed arch of the aorta 9 inches. 9 inches from the incisor teeth. 9 inches. The third contraction is crossed by the left principal bronchus, about 11 inches from the incisor of the teeth. From the incisor teeth. Is crossed first contraction in the pharyngo-esophageal region. In the pharyngo-esophageal region. The second is by the arch of aorta, and the third is the diaphragm, and the third is the principal bronchus. Is in the principal bronchus. Crossed with the principal bronchus. 6 inches, 9 inches, 11 inches, and then fourth contraction where it pierces the diaphragm in 16 inches. Pierces the diaphragm in 16 inches in the incisor teeth. This side of contraction, their effective distance from the upper inferior their vertebral levels are given in table 23.1. 6 inches, 9 inches at the arch of the aorta, 11 inches and the cross section of the principal bronchus, and 16 inches at the diaphragm, which is where it pierces the diaphragm. Diaphragm 16 inches. Pharyngo-esophageal. Site of pharyngo-esophageal junction, C6, 6 inches. A cross arch of the aorta, thoracic 4, 9 inches. Crossing of the left principal bronchus, thoracic 6, 11 inches. And each diaphragmatic region, 10, thoracic 10. Opening of the diaphragm region. Cervical 6, thoracic 4, thoracic 6, thoracic 10. 6, 4, 4, 6, 10. The narrow part of the esophagus is commencent at the sarcopharyngeal sphincter. Clinical significance of esophageal constrictions. The anatomical constrictions of the esophagus are considerable clinical importance due to the following reasons. These are the sites where swallow origin bodies are most likely to be lodged or stuck in the esophagus. These are the sites where structures develop from the ingestion of the corrosive substance. These sites have predication for the carcinoma of the esophagus. These are the sites through which it may be difficult to pass esophagoscope or gastric tube. Parts of the esophagus. Esophagus is divided into the following three parts: cervical part, thoracic part, abdominal part. So, cervical part is 4 inches, 9 inches, 11 inches, 16 inches. 9 inches, 6 inches, 6 inches, 9 inches, 11 inches, 16 inches. In the pharyngeal, so esophageal. The the cervical 4 centimeters, 20 centimeters, abdominal part 1 to 2 length, 1 to 2 centimeters in length, 4 centimeter, 20 centimeter, 1 to 2 centimeter. Cricoid cartilage to the The cervical part extends from the lower border of the cricoid cartilage. The cervical part extends from the lower border of the cricoid cartilage up to the border of the manubrium sternum. Up to the border of the manubrium sternum. The border of the manubrium sternum. And lower border of the cricoid cartilage to the superior border of the manubrium sternum, described in detail. The thoracic part extends from the superior border of the manubrium sternum to the esophageal opening of the diaphragm. Extends from the upper part of the manubrium sternum to the esophageal opening of the diaphragm. The abdominal part extends from the esophageal opening to the diaphragm to the cardiac end of the stomach. Esophageal opening of the diaphragm to the cardiac end of the stomach. Relation of the cervical part of the esophagus. For description, refer relation of tracheal part of the esophagus. Relation of the thoracic part in the esophagus. Anterior, from above downward, these are as follows: trachea, arch of the aorta. Relation of the trachea from anterior. Trachea, arch of the aorta. Right pulmonary artery. Left pulmonary bronchus. Right pulmonary artery. Left principal bronchus. Left atrium closed on its pericardium and diaphragm. Trachea, arch of the aorta, right pulmonary artery, left bronchial plexus. Right principal bronchus, left atrium closed by pericardium and diaphragm. Posteriorly, vertebral column, right posterior intercostal arteries. Thoracic duct and azygous vein, hemizygous vein, and descending thoracic aorta. And to the right lung and the pleura, azygous vein and right vagus nerve. To the left, arch of the aorta, left subclavian artery, thoracic duct, left lung and pleura, left recurrent laryngeal nerve, and descending thoracic aorta. In the esophageal aperture of the diaphragm, the left vagus nerve, now called a pteriogastric nerve, in the esophageal aperture, now called the gastric nerve, is related anteriorly to the right vagus nerve, now called the posterior gastric nerve, is related posteriorly. Posterior gastric nerve. And relations of abdominal part of the esophagus. Anterior, posterior surface of the left lobe of the liver, of the abdominal. That was the thoracic part of the esophagus. Now, relation of the abdominal part. Posterior surface, right lobe of the liver, anterior gastric nerve, right lobe of the liver, and anterior gastric nerve. Posterior, left crush of the diaphragm, posterior gastric nerve. Anterior gastric nerve, posterior gastric nerve. Anterior gastric nerve, posterior gastric nerve. The right lobe of the liver, and the left crush of the diaphragm. Anterior, posterior. The abdominal part of the esophagus is the shortest, 1 to 2 centimeters long, and it is only covered with serous membrane epithelium and arterial supply. Blood supply to the cervical part is by defined by the blood supply to the cervical part is by inferior thoracic arteries. Blood supply by inferior thoracic thyroid artery supplies. Blood supply to the cervical part is by inferior thoracic arteries. Inferior thoracic arteries. Inferior thyroid arteries. Blood supply to the thoracic part is by esophageal branch of the descending thoracic aorta and bronchial arteries and descending thoracic aorta, and in the artery blood supply to the abdominal part is esophageal branch of the gastric artery and inferior phrenic artery by gastric artery and inferior phrenic artery, gastric artery and inferior phrenic artery, gastric artery and inferior phrenic artery. Venous drainage. Cervical part is drained by inferior thyroid veins. Thoracic part is drained by azygous and hemizygous veins. Abdominal part is drained by the two venous channels, namely hemizygous vein and a territory of superior vena cava. Hemizygous vein and a territory of superior vena cava. Left gastric nerve and a tributary of portal vein. Thus, the abdominal part of the esophagus is the site of portocoval anastomosis. Clinical correlation. Esophageal varices. The lower end of the esophagus is one of the important sites of portocoval anastomosis. In portal hypertension, for example, due to the cirrhosis of liver, there is back pressure in portal circulation. As a result, collated channels of portocoval anastomosis only open to become dilated and tortuous of the esophagus varies. The rupture esophageal varies cause hematemesis, vomiting of blood, hematemesis. Esophageal varices. The lower end of the esophagus is one of the important sites for portocoval anastomosis. In portal hypertension, for example, due to the cirrhosis of liver, in the end pressure of the portal circulation. As a result, collateral channels portocoval anastomosis not only open but become dilated and tortuous from to the esophageal vein. Rupture esophagus varies cause hematemesis. Lymphatic drainage. For the cervical part, lymph is drained into the deep cervical lymph node. For the cervical part, lymph is drained to the cervical lymph nodes. For the thoracic part, lymph is drained to the posterior mediastinal lymph nodes. Cervical lymph nodes, posterior mediastinal lymph. For the thoracic part, lymph is drained to the posterior mediastinal lymph nodes. For the abdominal part, the lymph is drained to the gastric and cloac lymph nodes. Gastric and cloac lymph nodes drained to the gastric and cloac lymph nodes in the posterior mediastinal lymph nodes and in the cervical lymph nodes. Nerve supply. The esophagus is supplied by both the parasympathetic and sympathetic fibers. Parasympathetic fibers are derived from recurrent laryngeal nerves and recurrent laryngeal parasympathetic and esophageal plexus formed by the vagus nerve. They provide sensory, motor and secretory supply to the esophagus. The sympathetic nerve derived from the thoracic 5 to thoracic 9, the spinal segment for sensory and vasomotor. Referred pain of the esophagus. The pain sensation mostly arises from the lower part of the esophagus, as it is vulnerable to acid peptic esophagitis. Pain sensation are carried through the sympathetic fiber of thoracic 5 to thoracic 9 spinal segment. Therefore, esophageal pain is referred to the lower thoracic region and epigastric region of the abdomen. Epigastric region and lower abdominal region. At the times of becoming difficult to differentiate esophageal pain from the Vaginal pain. At times, it becomes difficult to differentiate esophageal pain from the vaginal pain. Anginal pain. Microscope structure. Histologically, esophageal tube from within outward is made out of following basic layers. Mucus. It composes of the following components: epithelium, high stratified squamous and non-keratinized. Highly stratified squamous and epithelium non-keratinized. Lamina propria contains connective tissue with plenty of lymph nodes. It may contain cardiac esophageal glands, cardiac esophageal glands, esophageal mucus glands in lower part of the muco mucosa, extremely thick and made out of long longitudinal layers of smooth muscle fiber. And submucosa contains mucus pharyngeal glands. They secrete neural projection esophagus and nucleus of acidic juice. Mucus layer. In the upper one third, it is made out of a skeletal muscle. Mucus layer. Upper one third is made out of a skeletal muscle. The middle one third is made out of both a skeletal and smooth muscle. And the lower one third is made out of smooth muscle. Fibrous membrane. It consists of dense connective tissue and many elastic fibers. Note 12. A clinical coordination in which the certified squamous epithelium of the esopharyngeal is replaced by the gastric epithelium is called a clinical condition in which the stratified squamous epithelium of the esophagus is replaced by gastric epithelium is called the Barrett esophagus. It may lead to esophageal sarcoma, development of the esophagus and trachea. The esophagus develops from the foregut and respiratory tract. Develops from the foregut diverticulum called the foregut diverticulum of the laryngotracheal diverticular tube. Laryngotracheal tube. For the following two important events occur in the development of the esophagus: separation of the laryngotracheal tube by formation of the laryngotracheal septum, regulation of the obliterated lumen. Note 12. The failure to canalization of esophagus leads to the esophageal arteries, and the maldevelopment of the laryngotracheal septum leads to esophageal atresia, and the septum between the esophagus and the trachea leads to the tracheoesophageal fistula. Clinical correlation. Radiological examination of the esophagus by barium swallow. Radiological examination of the esophagus by barium swallow. Esophagostomy, achalasia cardia, dysphagia, and tracheoscopial fistula. Carcinoma at the lower end of the esophagus. Lungs, pulmones. The lungs or pulmones are the principal organs for respiration. The two lungs, right and left, are situated in the thoracic cavity, one on either side. The mediastinum enclosed by the pleural sac. The main function of the lungs is to oxygenate the blood. That is the exchange of O2 and CO2 between inspired blood, air and blood. Each lung is large, conical, pyramidal shape with the base resting on the diaphragm and its apex resting on the root of the neck. The right lung is larger and heavier than the left lung. The right lung weighs about 700 grams and left lung about 650 grams. The right lung has 3 lobes and 4 lungs and the left lung has 2 lobes. The lobes are separated from each other by deep fissures. They are supplied by lobal bronchi. The lungs are attached to the trachea and heart by principal bronchi and pulmonary vessels, respectively. The lungs of newborn babies are those who live in a clean environment are rosy pink in color. But the lungs of those who live in a polluted areas or those who are smokers are brown or black in color, with mottled appearances due to inhaled carbon particles. In adults, the lungs are spongy in texture and crepitate on touch due to the presence of air in their alveoli. They float in water. The fetus and the stillborn children, the lungs are solid and do not crepitate on the touch due to the absence of air and alveoli. They sink in water. External features. Each lung presents the following features: apex, base, three borders, and two surfaces. Three borders are anterior, posterior, and inferior. Two surfaces are costal and medial. Anatomical position and side determination. The side of the lung can be determined by holding the lung in such a way that the conical apex is directed upward and its border and base is directed downwards. Its convex surface, costal surface, is directed upwards and its flat medial surface presenting helium is directed inward. Its thin margin, anterior margin, should face outward and its rounded border, posterior border, should face backward. Note well, the site should not be determined by the number of fissures and the lobes as they are variable. The external features are discussed in detail in the following text. Apex. The apex is rounded, blunt, superior end of the lung. It extends into the root of the lung about 3 cm superior to the anterior end of the rib and 2.5 above the medial 1/3 of the clavicle. It is covered by clavicular pleura and suprapleural membrane. Subclavian relations: anterior subclavian artery, internal thoracic artery, and scalenus anterior. Posterior, the neck of the rib and the structures in front of it. The example: venous ramus of the first thoracic nerve, superior intercostal artery, and first posterior intercostal vein, sympathetic chain. All the structures related to the apex are separated from it by the suprapleural membrane. Surface marking of lungs. Apex. It coincides with the clavicle part and the parietal pleura and cervical pleura. Margins. The lung margins approximately coincide with those of costal pleura. The lung margins approximately coincide with the costal pleura except at the following points. Anterior border. The anterior border of the left lung is a direct notch, has a distinct notch, which passes laterally behind the fourth and fifth intercostal spaces. Lower border. The lower border of each lung has two rib spaces higher than the lower border of the costal pleura. Thus, it lies along the line which cuts 6th rib in the midclavicle line, 8th rib in the midaxillary line, at 10th rib in the erector spinae borders at the ends of 2 cm to the spine or teeth and vertebra. Posterior border. The lower end ends at the level of the spine of the teeth and vertebra. Fissures. The oblique fissure is marked by a line drawn obliquely downward and outward from 1 inch or 2.5 centimeters laterally to the T5 spine to the 6th costal cartilage about half inch or 4 centimeters from the midline. Oblique is marked by a line drawn obliquely down towards from 1 centimeters, 1 lateral to the T5 spine, 6th costal cartilage, about 1 to 4 centimeters above the midline. Clinical practice. Ask the patient to abduct the shoulder to its full extent. The line of the oblique fissure in this position corresponds to the medial border of the roasting scapula. Transverse fissure is marked by a line drawn horizontally from the fourth costal cartilage. And meets the oblique fissure where the meets the cross fit. Protein, peptide, and amino acid. Protein. Classify proteins on the basis of their function with one example of each. Write down the functional classification of proteins with example. Briefly discuss about the functional classification of protein. Classify protein according to function. Classify protein according to biological functions. Give example from each. Enumerate the functional proteins with example. Short note: protein. Answer: protein. Proteins are high molecular weight nitrogenous macromolecular compound composed of one or more polypeptide chain of alpha amino acids linked together by peptide bonds. Proteins are high molecular weight nitrogenous micromolecular compound composed of one or more polypeptide chain of alpha amino acids linked together by peptide bond. Proteins are macromolecular polymers of amino acids linked together by peptide bond. Proteins are macromolecular polymers. Polymers are macromolecular polymers of amino acids linked together by peptide bond. Proteins are macromolecular polymer of amino acids linked together by peptide bond. Classification of protein based on chemical nature and solubility. Simple proteins composed of only amino acids residues without any non-protein substance. Composed of only amino acid residue without any non-protein substance. Conjugated protein. Besides amino acids, this protein contain non-protein substances called prosthetic group. Basis on solubility. Simple proteins. Simple proteins on basis of axial ratio also are divided into globular proteins. Axial ratio not over 3 or 4. Fibrous protein. Axial ratio is 10 or more. Example: collagen, elastin, keratin, and fibrillin. On basis of solubility. Albumin soluble in water, dilute salt solution. Globulin insoluble in water and soluble in dilute salt solution. Albumin, globulin, glutamine insoluble in water and double and soluble in dilute acid and alkali. Histone soluble in water but insoluble in dilute NH4OH. Chromatin soluble in water and NH4OH. Prolamine insoluble in water but soluble in 70% alcohol. Conjugated protein. Besides the amino acids, this protein contain non-protein substance called prosthetic group. Derived protein. These are the denatured or degraded products of simple and conjugated proteins. There are two types: primary and secondary. Primary derived from denatured or coagulation of simple conjugated proteins. Secondary derived from breakdown of peptide bonds. Derived protein. These are the denatured or degraded proteins of simple and conjugated proteins. There are two types: primary derived from denatured and coagulation of simple or conjugated proteins. Derived from denatured or conjugation of simple conjugated proteins. Secondary derived from breakdown of peptide bonds. So simple protein, conjugated protein, and derived protein on basis of biological function. They are contractile protein, actin, myosin, catalytic protein, enzymes, structural protein, elastin, keratin, collagen, storage protein, myoglobulin, ferritin, regulatory protein, calmodulin, peptide hormone and DNA binding protein, protective protein, immunoglobulins, blood clotting factors, transport protein, lipoprotein, transferrin and albumin, genetic protein, nucleoproteins. On the basis of source, nutritional classification. First class protein. Proteins of high biological value which contain all the essential amino acids are called the first class protein. Source: animal source, for example meat, fish, eggs, etc. Second class protein. Protein of low biological value which are poor in essential amino acids are called second class protein. Vegetables classes: cereals, beans, nuts, oilseeds, etc. Brief in short about the fibrous protein. Fibrous protein. General properties: fibrous like in shape, process high tensile strength, water soluble, resistance to digestion, chief component of tendon, ligament, cartilage, extracellular matrix, hair, nail, etc. Complex: collagen, elastin, keratin, fibers. Collagen, elastin, keratin, fibers. Fibrillin. Collagen most Abundant protein in human body, 25% of the total protein. Water insoluble rigid through the high tensile strength that cannot be stretched. Produced by fibroblast, osteoblast, and chondroblast. Found in the extracellular matrix, skin, bone, cartilage, tendon, ligament, cornea, etc. Disease associated with it: scurvy, osteogenesis imperfect, Ehlers Danlos syndrome, etc. Elastin. It has rubber-like properties, elasticity that can be stretched and again recoiled. Found on lungs, large vessel wall, elastic ligament, etc. Diasis associated with it, emphysema. Example: collagen, elastin, keratin. These are present in exoskeletal structures, for example, hair, nail, horn, etc. Fibrillin, abundant in found in lens, periosteum, aorta, etc. Diseases associated with it: Marfan syndrome. How can you make first class protein or from the second class protein? We can make first class protein from second class protein by combination of two or more second class proteins such as cereals, pulses, and vegetables. This is known as supplementary action of protein. Name the heme containing proteins. Name the chromoproteins. Answer: hemo containing protein, chromoproteins. Hemoglobin, hemoglobin. Myoglobin, myoglobin. Containing protein and chromoproteins. Myoglobin, myoglobin. Cytochrome A, B, and C catalase peroxidase. Cytochrome B 450. Cytochrome catalase peroxidase, rhodopsin, and flavoprotein. Give the important properties of protein mentioned in the color reactions of protein. General properties: nature colloidal, taste tasteless, odor odorless, molecular weight high, shape variable. It may be globular, oval, fibrous, and elongated. Solubility greatly soluble in water but insoluble in lipid solvent. Acidity and basicity: act as acid in basic solution and as base in acidic solution. Isoteric pH: each protein has a particular isoteric pH at which it is participated. Diffusibility: can't pass through semi-permeable membrane because they are colloidal. Osmotic pressure. Viscosity: elastic, electrophoric mobility. Optical isomerism, having no melting point. Chemical properties: denaturation: it is the disruption of secondary, tertiary, and quaternary structures of the native protein, resulting in alternation of physical, chemical, and biological characteristics. Denaturation. Chemical properties. Chemical properties include general properties and then chemical properties. Coagulation: most proteins undergo coagulation by heat or acid. Precipitation: proteins are precipitated from solution by heavy metal, salt, acid, alcohol. Colloidal reaction: Burette test, Millon's test, xenothoporetic test, Neutroprussic test, Ninhydrin test. Hydrogenation: proteins are hydrated in the presence of water. Burette test, Millon's test, and xenothoporetic test, Neutroprussic test, and Ninhydrin test. Proteins are hydrated in presence of water. Write down the biological importance of protein. Biological importance of protein: it is a structural component of cell membrane, organelles, and cytoskeletal structures. Enzymes catalyze biochemical reactions. Hormonal proteins regulate body functions. Transport HO2 and CO2 and hemoglobin. Ferrum by transferring by Cu by ceruloplasmin. Alpha-2-globulin. Bilirubin by albumin. Electron by cytochrome, and lipid by lipoprotein, etc. Antibodies help in defense mechanism of body. prothrog- prothrombin, fibrinogen, other clotting factors prevent bleeding by forming blood clot. Actin and myosin cause muscle contraction. They perform heredity transmission by nucleoprotein. Source of energy 4.1 kilocalorie per gram. Some protein help in storage of ferritin store ions. Act as receptors for hormones, neurotransmitters, and drugs. Act as carrier in membrane transport, for example, glucose and co-transport. Disease associated with protein maturation are Ehlers-Danlos syndrome. Disease associated with protein deficiency and protein energy malnutrition. Mentioned in the biomedical importance. Act as receptors for hormone, neurotransmitter, and drugs. Act as carrier in membrane transport, for example, sodium glucose co-transport. Disease associated with proteins maturation are and plasma proteins are a complex nucleus of over 200 of proteins that are structurally and functionally different from each other. Normal values of plasma protein. Source of plasma protein. Function of each plasma proteins. Albumin, globulin, fibrinogen, prothrombin. What is hemoglobin? Hemoglobin, function of hemoglobin. Short note, quaternary structure of protein. Structures of protein, primary structure, secondary structure, tertiary structure, and quaternary structure. What are the types of bonds in protein structure? Covalent bond and non-covalent bond. Non-covalent bond. Order, conformation, and order structure of proteins. Primary structure, secondary structure, tertiary structure, and quaternary structure. How protein structure is stabilized? Stabilization of protein structure: hydrogen bonds, ion and electronic interactions, van der Waals interactions, hydrophobic interactions. Give the properties of alpha helix. Alpha helix. What do you mean by domain? What do you mean by denaturation of protein? State of biomedical importance of nucleic acid. Functions of DNA, functions of RNA. Name the plasma proteins. Plasma proteins. Plasma proteins are a complex mixture of over 200 of proteins that are structurally and functionally different from each other. Normal values of plasma protein. Total plasma protein 64 grams per liter, 6.4 gram per deciliter. Serum albumin 35 to 50 gram per deciliter. Serous albumin, alpha globulin, alpha 2 globulin, beta globulin, or gamma globulin. Serum fibrinogen or serum prothrombin. Source of plasma proteins. All plasma proteins are produced by liver except the alpha gamma globulin produced by the plasma cells. Source of plasma proteins. Albumin maintains 70-80% of colloidal osmotic pressure in plasma. Maintains viscosity of blood. Acts as buffer and maintains acid-base balance. Act as a carrier of calcium, fatty acid, bilirubin, hormone, and drugs. Act as a protein reservoir. Beta globulin maintains 20% of colloidal osmotic pressure in plasma. Helps in maintain viscosity of the blood. Alpha 1 globulin transports lipid in steroids. Alpha 2 globulin transports Cu as seroplasmin. Beta globulin transports Fe as transferrin. Gamma globulin acts as antibody fibrinogens, essentials of the blood coagulation. Increase ESR and helps to maintain viscosity of blood. Prothrombin helps to coagulation of blood. What is hemoglobin? State the major functions of hemoglobin. Hemoglobin is a red pigment of blood and comprises of chromoprotein consisting of non-specific simple proteins called hemoglobin and specific prostatic groups called heme and iron containing pigment. Functions of hemoglobin: transports O2 from the lungs of the tissue and CO2 from the tissue to the lungs. It is an important blood buffer maintaining acid-base balance of the body. Formation of various pigments, for example, bilirubin, astarcobilin, urobilin, etc. It reserves iron and protein. Short note: quaternary structure of protein. Quaternary structures of protein. Structures of protein can be divided into four levels of organization. They are primary, secondary, tertiary, quaternary. Primary: the linear sequence of amino acids linked together by peptide bond forming the backbone of the protein is called primary structure. For example, human insulin. Secondary structure: the conformation of polypeptide chain by twisting, folding, and coiling is referred to as secondary structure of protein. Bonds essential for forming the secondary structure are hydrogen bonds and disulfide bonds. For example, it is found in fibrous protein and, for example, collagen, elastin, and keratin. Tertiary structure: the three-dimensional arrangement of the protein structure is referred as tertiary structure. It is such a type of structure that which is biologically active. Bonds essential for tertiary structure are hydrogen bonds, ion interactions, van der Waals interactions, and hydrophobic interactions. Example: it is found on albumin, globulin, antibody, etc. Quaternary structures. The quaternary structures of protein fields refers to the arrangement of two or more polypeptide subunits which are held together by non-covalent interactions. For example, hydrogen bonds, ionic bonds, van der Waals interactions, and hydrophobic interactions. For example, hemoglobin, lactate hydrogenase, keratinase, etc. What are the covalent bonds in protein structure? Types of bonds in protein structure: covalent bonds, peptide bond, disulfide bond. Non-covalent bond: hydrogen bond, electrostatic bond, van der Waals interactions, and hydrophobic interactions. Briefly describe the orders of the protein structure. Orders: conformation and order structure protein. Primary structure: peptide bond. Secondary structure: hydrogen bond, disulfide bond, alpha helix, beta bands, and random coils. Tertiary structure: hydrogen bonds, van der Waals interactions, and hydrophobic interactions. Quaternary structure: hydrogen bonds, ion electrons, van der Waals interaction, hydrophobic interactions. How protein structure is stabilized. Stabilization of protein structure. Hydrogen bonds: it is found between CO and NH groups of two different peptide bonds. Two different peptide bonds is also formed on OH group, serine, and COOH acid amino acids. Iron electrostatic interactions. These interactions occur between oppositely charged polar size groups of amino acids. They are lysine, arginine, histidine, and acid amino acids. Van der Waals interactions. Therefore, occur between nonpolar acid chains and amino acids. Hydrophobic interactions. They occur between nonpolar acid chains and amino acids such as alanine, phenylalanine, etc. Give the properties of alpha helix. Alpha helix is the most common spiral structure of protein. It has a rigid arrangement of polypeptide chain. The saline features of alpha helix are given below. The alpha helix is tightly packed with coil structures with amino acid side chains extending forward from external axes. The alpha helix is stabilized by extensive hydrogen bonds. It is formed between hydrogen atom attached to the peptide and an O atom attached to the peptide C. Hydrogen bonds are individually weak, but collectively they are strong enough to stabilize the helix. All the peptide bonds except the first and the last in a peptide chain participate in hydrogen bonding. On each turn of alpha helix contains 3.6 amino acids and travels a distance of 0.74 nanometer. The spacing of each amino acid is 0.15 nanometer. Alpha helix is a stable conformation formed spontaneously with the lowest energy. The right right-handed alpha helix is more stable than the left-handed helix. A right-handed helix turns the direction that the fingers of the right hand curl when its thumb points to the direction of the helix rises. Certain amino acids, particularly proline, disrupt the alpha helix. Large amount of acid or basic amino acids also referred to with alpha helix structure. What do you mean by domain? Domains are the fundamental structures and the three-dimensional structures unite of polypeptide. Polypeptide chains are greater than 200 amino acids in length, generally consisting of two or more domains. The core of a domain is built from combination of super secondary structure elements. Folding of the peptide chain within a domain usually occurs intermediately of folding another domains. Therefore, each domain has the characteristic of small upcoming globular proteins that is structurally independent of the other domains in the polypeptide chain. Importance of primary structure proteins. This primary sequence of proteins provide both molecular and fingerprint for the identification and information that can be used to identify the clone and the genes that encode it. The primary structure of protein is important because many genetic diseases result in the protein with abnormal amino acid sequences. If the primary structure of the normal and abnormal proteins are known, the information may be used to diagnose or study the disease. What do you mean by denaturation of the protein? Denaturation of the protein may be defined as the disruption of the secondary, tertiary, and the quaternary structure of the native protein, resulting in automatic physical, chemical, biological characteristics protein by varying of agents. The naturing agents, physical agents, X-ray, UV ray, ultrasound, extreme temperature, etc. Chemical agents, a strong acid, strong alkali, high urea contraction, heavy metal salts, ethanol, and detergent, etc. Result of denaturation. Primary structure with peptide linkage remains intact, but secondary, tertiary, and quaternary structures are lost. Denatured protein loses its biological activity. Denatured proteins cannot be crystallized. Denatured proteins are less soluble and so can easily be participated. Enzymatic and hormonal activity is diagnosed by denaturation. Usually it is irreversible process, boiled egg, cooked meat, etc. But it may be irreversible. Denatured proteins become insoluble in the solvent in which it is originally soluble. Nice to know, conjugated proteins produced by irreversible denaturation with the extracellular intramolecular change is called conjugated protein. They are insoluble and participate out. All coagulant proteins are denatured proteins, but all denatured proteins are not coagulant proteins. State that biomedical importance of nucleic acid. Nucleic acids are polymers of nucleotides required for storage and transmission experience of genetic information. Two types: deoxyribonucleic acid and ribonucleic acid. Function of DNA. They are chemical vehicles of heredity. They are stored in express genetic information. They serve as template for transcription of information into RNA and replication of information into DNA molecule. Functions of RNA. Nearly all of several species of RNA are involved in some aspect of protein synthesis. Messenger RNA mRNA carries genetic information from the muscular cytosol, where it is used as a template for protein synthesis. Ribosomal RNA has a structural role of contributes its formation to ribosome. Transfer RNA tRNA transfers the amino acid from cytoplasm to ribosome form protein synthesis. Wintrobe's method. Apparatus. Picking apparatus, disposable syringe and needle. Syringe waves moist with 70% alcohol. Decorated penicillin bottles with powdered double oxalate mixture, 6 gram amino oxalate 4 gram potassium oxalate. Winthrop tube with stand. Winthrop tube is an 11 centimeters long heavy syringe glass tube with a uniform bore diameter of 2.5 millimeter. Its lower end is close and flat. This tube is calibrated in centimeters and millimeters from 0 to 10 centimeter above downwards on one side of the scale for ESR, and 0 to 10 to 0 centimeter on the other side for PCV. Each centimeter is further divided into millimeters. The mouth of the tube can be covered with a rubber cap to prevent loss of fluid by evaporation. A Winthrop stand is provided for holding the tube upright when doing ESR. The Winthrop stand can hold up to 3 or 6 tubes at a time. Pasteur pipette. It is a glass tube drawn to a long thin nozzle about 14 centimeters long. A rubber thread is provided to suck blood into the pipette by a slight pressure. It is used for filling the Winthrop tube centrifuge machine. It packs the red cell into HCT tube by centrifugal force. The magnitude of force produced by rotation of the tube depends on the radius. For example, the distance between the center to the shaft of the bottom of the centrifuge tube when laid horizontally. The number of revolutions per minute. In terms of gravitational force, the value of force should be 2260 units. This much force is created when the radius is 9 inches and the speed is 3000 rpm. Revolutions per minute. Procedure: draw 2.0 millimeter of venous blood and transfer it to container of anticoagulant. Mix the contents gently but well by innervating the vial a few times or by swirling it. Do not shake, as it will cause frothing. Using the Pasteur pipette, fill the Winthrop tube from below upwards, ensuring that there are no air bubbles. Transfer the tube to its stand and adjust the screws so that it will remain vertical. Leave the tube undisturbed in this position for 1 hour, at the end of which read the millimeter of the clear plasma above the cell. Procedure: draw 2 millimeters of venous blood and transfer it to a container of anticoagulant. Mix the contents gently by innervating the vial of a few times or by swirling it. Do not shake, as it will cause frothing. Using a Pasteur pipette, fill the Winthrop from the below upwards. Ensure that there are no air bubbles. Transfer the tube to its and adjust the screws so that it will remain vertical. Leave the tube undisturbed in this position for 1 hour, at the end of which read the millimeter and clear plasma above the red cells. Normal values: males 0 to 9 millimeters at the end of first hour. Females 0 to 20 millimeters at the end of first hour. The Westergren's method. Westergren's method apparatus: a 2 millimeter disposable syringe with needle, sterile cotton, groove swabs moist with alcohol, discarded penicillin bottle, sterile solution of 3.8 sodium citrate as the anticoagulant. Sterile solution of 3.8 sodium citrate. Westergren's pipette and stand. A Westergren's pipette is 300 millimeters long, open from both ends, and has a bore diameter of 2.5 millimeter. It's calibrated in centimeters and millimeters from 0 to 200 from above downwards. In its lower two-thirds, The Western stand can accommodate 4 or 6 tubes at a time. For each pipette, there is a screw cap that slaps over its top and at its lower end, and pipette presses into a rubber pad or cushion. When the pipette is fixed in position, there is enough pressure of the screw cap to prevent leakage from blood from its lower end. Procedure: draw 2 millimeters of venous blood and transfer it to a vial container of 0.5 of 0.5 milli of 3.8 sodium citrate solution. Fill the Western grains pipette with blood citrate mixture. Draw 2 milliliters of venous blood and transfer it into a vial container containing 0.5 millimeter of 0.5 milliliter and 3.8% sodium citrate solution. This will give a blood citrate ratio of 4.1. Mix the contents by inverting or swirling the vial. Do not shake as it will cause frotting. Find the Western pipette with blood citrate mixture by shaking. After placing the tip of your finger over the top of the pipette to control the flow of the blood into and out of it, or with a rubber bulb, bring the blood column to exactly 0 mark. If there is a difference of 1 to 2 millimeter, it should be noted and taken into account before giving the final report at the end of an hour. If there is a difference 1 to 2 millimeter, keep your finger or the rubber bulb over the pipette. Transfer it into a Western grains. Leave the pipette undisturbed for an hour, at the end of which read the millimeter of clear plasma above the red cells. Express your results millimeter in the end of first hour. Western grain normal values 3 to 5 millimeters at the end of first hour, 4 to 7 millimeters at the end of first hour. Source of error: tilting of the tube and high temperature can lead to high values. Tilting the tube, low temperature gives false low values. Hemolyzed blood may obscure the sharp line of spurting red cells into the plasma. Hemolyzed blood may obscure the sharp line separating the red cells and plasma. Hemolyzed blood cells. Precautions: all glass apparatus like tubes or pipettes should be absolutely dry. Causes the pulmonary